As we know, pain control is very important to hospice patients, and we deal with it on a daily basis. Pain control is one of the top three priorities for dying patients if you ask them what's most important to them. It also has a great deal to do with patient and family well-being and their overall hospice experience. If they have poor pain control, they're going to give poor feedback. And pain levels affect other symptoms, physical symptoms, mobility, emotional symptoms, interpersonal interactions with family and friends, and just the overall acceptance of the terminal diagnosis for which they're on hospice. So our goals in this talk are going to be to discuss basic patient evaluation related to pain and go through treatment options. Just some general concepts regarding pain. There's more than one type of pain. We're going to talk about somatic pain, visceral pain, and neuropathic pain. And just remember that anxiety and depression have effects on pain control and vice versa. Poor pain control can cause people a lot of anxiety and depression, so they go hand in hand. We're not going to go into a lot of detail about the pathophysiology of pain. It gets fairly complex, but just to note that when someone's having pain, obviously something's not right. There's a survival mechanism kind of built into our bodies, and if everything's completely normal, then you don't have pain. So obviously there's something wrong when people are having pain. There are pretty complex pain pathways, different nerve fibers and pain receptors that really are outside of the scope of this talk, so we won't cover those in any detail. Just some general considerations when discussing pain control with families and patients. It has to do with the patient and family expectations. I see those as being on a continuum where some patients want, complete pain control and don't care if they're a little sleepy, whereas some patients will want to be fully awake and are willing to accept a little higher pain level. Families' expectations may not always meet what the patients are wanting, so we have to balance that out following the patient's lead and what their wishes are. And then just to teach and remember that there's a lot of misconceptions in the community about a movie star death where someone will take their last breath with their family members around. And as we all know, that's not always the case, and the dying process can be complicated and not a pretty sight. So giving them some education on that is important. And on to patient evaluation. Physical findings, we're always looking for reversible causes of pain. Severe constipation or a partial bowel obstruction from constipation can be treated and improve pain symptoms. Urinary retention, with someone pain in the suprapubic area and you feel their abdomen and it feels like a 6-month pregnant uterus, a Foley catheter placed can really improve that patient's pain. Looking also for shingles, rashes over time in the dying patient. Some people will develop that, and we can get them started on antiviral medications, which will help their pain. Other things to talk about in your history and physical is, the duration of the pain. Is this new or is it some chronic problem? The intensity, where it sits on the pain scale of 0 to 10. Are there exacerbating factors? And then nonverbal signs that they might be showing. The 3 types of pain we mentioned earlier. Somatic pain is usually a throbbing, aching, localized pain related to tumor growth. Visceral pain is more abdominal usually, and it's a cramping, spasmodic pain that comes in waves. Somebody might have 0 pain and then 30 seconds later have it peak with visceral pain. And then neuropathic pain is sharp, stabbing, and electric shock kind of a pain symptom, and that's usually when a nerve is being impinged upon by a tumor or something else. I throw these last 2 in just for completeness. Psychogenic pain versus drug seeking. Psychological stressors can make even mild pain worse. So if you identify that, that's important, that we treat their psychological stressors if possible. And then drug seeking, obviously, conscious behavior that is someone trying to obtain drugs illicitly for illegal use. And then I throw fibromyalgia pain in here. We probably won't make this diagnosis. Someone will come to us with that, but fibromyalgia pain is a central nervous system sensitization pain syndrome where you're hypersensitive to peripheral pain signals. And narcotics really don't help that, so we try to avoid adding narcotics or escalating narcotics in people who have fibromyalgia type pain. As far as the treatment options, non-pharmacological things we all know. Nurses are doing this on a regular basis. Changing the patient position in bed can make a difference. Maybe they need a different bed or a different mattress, or maybe their Foley just needs to be adjusted. These are all things we can try to do before we start medications. And just some medication considerations in general. We're looking at potency versus things that are on the formulary as well. So different potencies of medications, and then if they're not on the formulary, then we have to get prior auth to get them approved. The route of the medication, whether it's still PO pills or need to be liquid or a patch form on the skin. And then the dosing and frequency, PRN versus scheduled. It's okay for us to start someone on a PRN dose. In fact, if they've got family members around, that would be preferable, just to see how they react to the medication. But if someone's in a assisted living facility and they get a med tech passing by their room once every 4 hours, PRN medication's probably not going to work, and we'll have to use a scheduled high interval, twice a day to start with, and then adjust from there. So the place of care has a lot to do with whether you start with a PRN or a scheduled pain medication regimen. But if we are using PRNs and you notice that someone's using at least 4 to 6 times a day, then we need to consider either scheduling it or increasing the dose or converting to an ER form of medication. And I think in general, when dosing pain medications, depending on the family's interaction and willingness to participate, the goal should never be to have family, patient, or caregiver have to take any kind of medication more than every 4 hours, because that means they're up and down all night long. And then another important thing about dosing and frequency of pain medications is follow-up. Call the patient the next day, make sure the medication actually arrived. Did they get it started? How did it help? And those types of things. And then finally, titration. This is also a really important point about dosing pain medication. If you're wanting to increase a dose or do a titration to another medication, we really have to know, the provider has to know the total daily dose that they're taking. It doesn't do any good to know that their order says 10 milligrams of morphine Q4 hours if we don't know how many times they've actually been given that. And when we're adjusting or cross-titrating specifically, there's an app that we use to do that so that it's equal dosing depending on the medication you're changing to. And then finally, on medication considerations, just doing gradual increases in the total daily dose so that we don't overshoot and end up making the patient lethargic. Side effects of the pain medications, we all know a lot of these, but just to refresh, constipation is a big one with the narcotics, obviously. My rule of thumb is someone's on a PRN narcotic, they need at least a PRN bowel med on hand so that they don't get behind. If somebody's on a scheduled routine narcotic, they really need a scheduled routine bowel med. And you can always back off if they end up having loose stools. Nausea and vomiting related to pain medication. This is really patient specific. Some people react differently to all these different meds. Sometimes it's time limited. It just happens with the first few doses and might improve. But we might have to do a rotation to another pain medication. Rashes and itching are kind of the same way. If it's minor symptoms, we just need to treat those symptoms. If they get a little itch, maybe some hydrocortisone or Benadryl. We just don't want to switch pain medications at the first sign of a little itch, because then you burn through some of the others that you really can't use that are similar. So that's some of the pros and cons of switching immediately versus trying to get the patient to stick it out a little bit longer. Myoclonus is the single jerking motion that people get, like if you're falling asleep, if your head is ever nodded and you jerk yourself awake, that's myoclonus equivalent. If you start to see that, it's usually with higher doses of narcotics, and it's time to either rotate to a different medication or add a benzodiazepine, depending on what stage the patient's in and their progress. Hyperalgesia or allodynia is really just when someone gets a hypersensitive to touch everywhere, even on the forehead, and all of their extremities, even just touching their skin, then that is hypersensitivity to the narcotics, and actually dose decreases or rotation to a different narcotic is needed, not just keep bumping up the narcotic dose they're on. And then chronic kidney disease, CKD4-5, or a GFR less than 30, we really need to be, even in these end-stage patients, avoiding NSAIDs. Tramadol is relatively contraindicated in renal failure, as well as morphine. And so if someone just comes off dialysis, or we know that they're an end-stage renal patient, we should be using hydromorphone or fentanyl or methadone. Those three are not as heavily cleared by the kidneys. So the non-narcotic pain medications, the NSAIDs, the anti-inflammatories, ibuprofen, naproxen, or meloxicam, those can all still be used early on if patient has mild pain symptoms, or if we think it's arthritis type pain symptoms. Tylenol, muscle rubs, Sarna lotion is one. And then lidocaine patches or cream are on our formulary, so that's something we can consider. We really don't use capsaicin cream that much, but that's available. And then gabapentin, especially for neuropathic pain, but sometimes used as augmenting other pain medication. Tramadol for mild pain, and then muscle relaxers kind of fit under that non-narcotic pain medication regimen. So we'll move on to kind of the meat of things, which is the narcotics. The oral preparations that we use, these are listed in kind of increasing potency in this list. Most of the time we'll start with either hydrocodone, acetaminophen, or oxycodone. The hydrocodone, also Norco is another name, or Vicodin, comes in 5s, 7.5s, and 10s-325. In the tablet form, it also comes in a oral solution, 7.5-325 in 15 cc's if someone's got a tube or has trouble with pills and they want to still use that medication. Percocet, we use that some if they come to us on it. I don't usually start with that because we get into trouble as we escalate doses, getting too much Tylenol in a 24-hour period. But those come in 2.5, 5, 7.5, and 10-325 on our formulary. And then oxycodone IR or Oxy-IR. I just want to make sure everybody realizes I've heard some nurses conflate the name oxycodone with OxyContin. OxyContin is the ER version of oxycodone, so you have to be very specific if you're talking about Oxy-IR versus Oxy-ER. The Oxy-IR we use quite a bit. It comes in 5 milligram capsules or 5, 10, 15, 20, 30 milligram tabs. And then the standard solution is 5 milligrams per 5 cc's, but that can be compounded by 1 point for higher concentrations and lower volume. Unfortunately, oxycodone ER or OxyContin is non-formulary, so we don't use that very much. There's a lot of other alternatives we can use. It would be rare for us to prior auth and get OxyContin. And then on to kind of our workhorse medications. Morphine, immediate release, or MSIR, is pretty much our go-to medication for hospice patients. It's in our e-kit, but it does come in 5 and 10 milligram capsules and 15 and 30 milligram tabs. And then our standard concentration is 20 milligrams per cc, but it can be compounded in a 50 milligram per cc oral solution. We don't use it much, but it comes in suppositories and obviously in injectable concentrations as well. And obviously just make sure you're distinguishing morphine IR versus MSER, or the brand name is MS Contin. Also, the thing to monitor and look for in one point is that you're picking the 8/12 hour formulation and not the 24-hour formulation. The 24-hour formulation is not on our formulary and is fairly expensive. We usually just use the 8/12 hour. And that 8/12 hour MSER comes in 15s, 30s, 60s, 100s, and 200s in tablet form. Hydromorphone, which again would be for either people who can't tolerate morphine or are end-stage renal disease patients. That's brand name is Dilaudid. That comes in tablets 2, 4, and 8 milligrams and various concentrations of either 1, 2, or 10 milligrams per cc that they can compound. And then last is methadone on the oral preparations. Methadone has a really long half-life, so we can't make dosage adjustments any sooner than maybe 5 days. So if someone starts on a low dose of methadone and we're gradually titrating because of the metabolism of that drug, it can take 5 days or so for it to stabilize, but that comes in 5 and 10 milligram tabs and in 10 and 50 milligram per cc solution. Methadone also has a lot of neuropathic pain effects as well, so we might sometimes switch to that. And finally, the patch preparation. The main one we use here is fentanyl, or the brand name Durgesic. It comes in 12s, 25s, 50s, 75s, and 100 microgram patches, which are used every 72 hours. We usually don't start opioid naive patients on anything higher than 12 micrograms. So if they've been on Norco or oxycodone or any of those and they're not getting pain relief, if they're using enough of that, we can start at 25 micrograms. But if it's just somebody who can't take oral and they're starting out brand new on narcotics, we'll usually be starting with the 12 microgram patch. So just in conclusion, the patient evaluation and patient and family expectations and matching those up, I think are probably our biggest goal. And then it's just a education process about, dosing frequencies, how much are they actually giving, give patients, families a 3x5 card and have them, keep track of when they give doses if it's always a guess as to how much they're actually giving. And then just keep it simple. There's no reason to have, 2 or 3 different pain medications in the house. And we want to make it simple as far as dosing frequencies, trying to at least get to every 4 hours on oral preparations. If not, we need to make adjustments. And that's it. Thank you.